Hello and welcome to Managing AML. I am Dr. Naval Davar and today I am joined by my colleague Dr. Courtney DiNardo. Today we will discuss new data in acute myeloid leukemia and how it translates to practice by reviewing 4 different case scenarios. This is the first case. This is a 57-year-old with fatigue, shortness of breath, and loss of appetite for the last 4 weeks, seen by his primary care doctor, chest x-ray with no abnormalities. Here you see the blood counts, white count of 27, hemoglobin's 8, platelet count of 34,000. Slightly elevated creatinine and LDH, other electrolytes are within normal range, has a good ECOG performance status, works as a mechanical engineer, has continued to work full-time at this time, has hypertension and no other comorbidities, and no family history of malignancy. Is a non-smoker, occasional alcohol use 1 to 2 times per week. So the patient, as is usually done, is referred same day to the hematologist and a bone marrow was done. This showed 77% blast, consistent with acute myeloid leukemia, no dysplastic changes. The cytogenetics were rushed, and these came back 3 to 4 days later, showing a diploid karyotype. Molecular panel was also rushed, and the NGS showed FLT3 ITD mutation with an allelic ratio of 0.58, NPM1 mutation, and DNMT3A mutations. So at this time, I will ask Dr. DiNardo, is this a common patient that you would see, and what would be your initial thoughts for this patient?
I think, well, certainly AML is not a particularly common cancer, but in terms of AML, this is one of the more common case scenarios we will see, which is a relatively young, in the terms of AML, kind of 40s to 50-year-old, presenting with a elevated white cell count, and in the setting of a high white cell count, kind of proliferative disease, and oftentimes we'll see an intermediate type cytogenetic, diploid cytogenetics with a FLT3 ITD mutation. So I think in my mind, when I'm seeing a patient with leukocytosis with a white count higher than normal, I'm always thinking, could this patient have a FLT3 ITD mutation?
Yeah, and I think that's the key with this leukocytosis, as we discuss in our meetings very frequently in the leukemia department here at MD Anderson. Some of our first thoughts are a FLT3 mutation, and then sometimes we're seeing RAS-MAP kinase mutations also presenting with such proliferative features, PTPN11, RAS. So these are patients we usually want to wait for molecular testing. Of course, they're proliferative, so you want to control their white count. You can admit them, do hydria. Sometimes we give 1 dose of cytarabine if they're really proliferative, white count above 70, 80. But we definitely want to get their FLT3 testing, especially since we enroll many of these patients on frontline FLT3 trials. But in the community, these would be the patients you want to look out for use of frontline FLT3 inhibitors, such as with midostaurin, sorafenib, or gilteritinib. So just to throw it out there, what are the treatment options for this patient? So these are, we have a good situation now in AML emerging where we have a lot of good treatment options, but still there are some that are better than others for a given scenario. So these are all approved treatments or NCCN guideline-based treatments, azacitidine venetoclax, of course 3+7 standard, FLAG-IDA that is being used quite frequently in many countries as well now in many centers in the US, 3+7 with midostaurin, which is a multi-kinase inhibitor that also targets FLT3, induction therapy with gilteritinib, which is second-generation FLT3 inhibitor, or 3+7 with gemtuzumab, ozacomycin, CD33 antibody drug conjugate, which is also approved in the frontline setting, used more frequently in core binding factor type of acute myeloid leukemia. So here I would ask Dr. DiNardo, what would your thoughts be for this patient? Which regimens would you consider, and how would you approach the patient?
Right. I think, I think the most important thing in a patient with a, and it is, well, first of all, I suppose, is deciding, is your patient going to receive an intensive chemotherapy-based or non-intensive chemotherapy-based treatment? And what we have heard so far from this patient, who is in their 50s, who has a good performance status and doesn't have any significant underlying comorbidities, this is definitely someone I would be thinking for an intensive chemotherapy regimen. And given the FLT3 ITD allelic ratio, I would be prioritizing an intensive chemotherapy with a FLT3 inhibitor. And so, so I think options 4 and 5 on my list are top. If you are at a community center around the world, 3+7 with midostaurin is the standard here. We are participating in several clinical trials with second-generation FLT3 inhibitors that may kind of surpass the role of midostaurin in the future.
Yeah, absolutely. I think the key here is, given the FLT3 mutation, we absolutely would be preferring a FLT3 inhibitor-based midostaurin currently approved based on the RATIFY study that I'll discuss, but a lot of excitement and in the large academic centers, movement towards using the second generation FLT3 inhibitors like gilteritinib up front. I'll show some of that data to show why we're excited about this. So one of the key things now in acute myeloid leukemia is that we do require molecular mutation testing at baseline for all patients. This is both for prognostic value as well as for therapy selection. So as you see, the ELN 2017, which will likely be updated in the near future, already does incorporate different molecular mutations in addition to the traditional cytogenetics that we have been using for acute myeloid leukemia prognostication. And so you see here NPM1, FLT3 mutations, and others such as ASXL1, TP53, RUNX1 have now been identified as independent prognostic impact mutations that could put a patient in a higher or lower group. The other important thing is that individual mutations, while important, are not giving us the complete story. So as you can see, if somebody emails me, which we do get a lot of emails like this, saying, I have a 50-year-old with a FLT3 mutation, what do you suggest? I really cannot give any clear guidance, because if that patient has a low FLT3 allelic ratio with an NPM1, the patient potentially could be a more favorable. On the other hand, if that patient has a high FLT3 ITD burden with no NPM1, then that patient is adverse. So you can see having a FLT3 mutation alone, you could still be in favorable, intermediate, adverse, and we really need to know the allelic burden or allelic ratio as well as the co-mutations. And this is just the beginning. We now know that other co-mutations, such as having DNMT3A along with NPM1 FLT3, could further have a prognostic impact, maybe TET2 and others. So I think this field will get more and more fine-tuned with time. So one of the first things that started occurring with the FLT3 mutations is when we identified that these were adverse prognostic factor, we started taking these people to transplant. This is one of the initial papers now 12 years ago that showed the impact of transplant in improving outcomes in patients who had FLT3 mutated AML. This benefit was specifically seen in FLT3 mutated. There was not as much as a benefit in people who had mutated NPM1 without FLT3. So transplant has been one of our go-to approaches for all FLT3 mutated patients in the frontline setting. The next thing that we have been looking at is incorporation of novel FLT3 inhibitors. So as you can see in this slide, there are many different FLT3 inhibitors that are now available, either approved or in clinical trials for treatment of FLT3 mutated AML. These include approved agents, midostaurin in combination with induction chemotherapy, as well as in the relapsed refractory setting, gilteritinib, which is approved in the United States, and quizartinib, which is not approved in the United States, but approved in Japan and is being evaluated in frontline phase 3 study. In addition to this, there are other FLT3 inhibitors, such as crenolanib, Hanmi drugs, Fujifilm, that are also in advanced clinical development at this time. I'll briefly go over the design of the RATIFY study. This was a very critical study. In fact, the first frontline study showing a targeted therapy added to backbone induction chemotherapy could improve outcome. Here we used a backbone of 3+7 and patients received either 3+7 with midostaurin or 3+7 placebo in the frontline setting. These were all FLT3 mutated patients, either ITD or TKD, and the primary outcome was survival. The midostaurin here was given on day 8 through 21, continued with the consolidation on day 8 through 21, and then patients could continue maintenance with midostaurin daily continuously for up to 1 year. Here are the results of the study. As you can see, the overall survival was significantly improved with a 4-year survival of 51% compared to 44% in patients who received midostaurin with 3+7 versus those who received placebo. Importantly, what was seen is that the benefit of midostaurin was noted across all ITD high, ITD low, and TKD mutations. Now, in the end of the day, although this is an improvement, it is not a game changer yet. We think this was the first important step in identifying FLT3 as a prognostic mutation, applying it in the real world setting, incorporating a multikinase inhibitor, and improving survival. However, if you do use midostaurin and take the patient's transplant, so not just doing one thing, but doing both approaches, then you may really get an improvement in outcomes. So if you catch your patient like this patient with a FLT3 ITD mutation, you add midostaurin to your induction backbone, and you try to take that patient transplant quickly in the first remission, ideally after 1 or 2 cycles of treatment, then you can see those patients could have up to 60-70% 4-year survival, which is dramatic because historically, FLT3, when first identified, they had a 4 to 5 year survival of only 20 to 30%. So it's usually not just one intervention, but a combination of interventions that is going to give you a real benefit. The third step that emerged was the addition of a post-transplant maintenance. So you identified FLT3, you gave a FLT3 inhibitor with induction, you took the patient to transplant, let's say after 2 or 3 cycles. Everything has been done well. Now, can you further improve that? And the data now suggest, with 2 randomized phase 2 studies, one out of the German cooperative group, other out of China, showing that addition of a post-transplant maintenance with the FLT3 inhibitor, sorafenib was the one used in those 2 studies, significantly improved both event-free survival and overall survival. And at our centers and many large academic centers, we are trying to put 100% of our patients post-transplant who have a FLT3 mutation on a FLT3 inhibitor. Now, we believe gilteritinib is a more effective and potent drug, and there is a large phase 3 post-transplant maintenance study of gilteritinib versus placebo that has completed enrollment through the Bone Marrow Transplant Network, and we hope to see that data. But at our center, we are frequently using gilteritinib post-transplant maintenance, but if one is not comfortable with that, I would definitely recommend using sorafenib, but some form of FLT3 inhibitor maintenance post-transplant. And now, after step 1, 2, 3, we said, well, we believe gilteritinib, maybe quizartinib, crenolanib are highly effective drugs. They've shown single agent activity of 50% compared to 5 or 10% with sorafenib midostaurin. Can this be leveraged into combining them up front and further improving this outcome with transplant and with post-transplant maintenance? And so this is some of the early data from the phase 1 studies that combined the second generation FLT3 inhibitors, as we call them, such as gilteritinib, crenolanib, quizartinib, with the backbone of 7+3. And again, these are different studies, so we're doing cross-study comparisons, phase 3 versus phase 1, a lot of caveats there. But again, we look at encouraging response rates 90% and higher with the second generation FLT3 inhibitors. So this is what has got us excited, that if we use a second generation FLT3 inhibitor, take the patient transplant, do maintenance maybe with second generation drug like gilteritinib, then we could potentially get up to 80% or so remission and cure rates, which would be outstanding. Very similar to the paradigm that's emerging, for example, in Philadelphia positive ALL, with ponatinib being used upfront after transplant, and we're getting to 75-80% 5-year survival rates. So at this time, I'll turn it back to Dr. DiNardo. And we've used a lot of different FLT3 inhibitor combinations with gilteritinib, quizartinib, midostaurin. What are some of the side effects that you've seen, and how do you kind of use this regimen in practice?
I think the most important side effect to be aware of when we are using FLT3 inhibitors is GI toxicity and probably QTc prolongation, particularly with the second generation FLT3 inhibitors like gilteritinib and quizartinib. I think all of them are fairly straightforwardly managed in terms of nausea, vomiting, diarrhea. We have good antiemetic and supportive care, but it's just something to be aware of. I think especially with midostaurin and sorafenib, the first generation, there is a lot of GI toxicity. And then in terms of the QTc monitoring, I think we need to pay attention to the many other QT prolonging medicines that are very standardly used in patients with AML. For instance, fluoroquinolones, azoles, the antiemetics themselves. So monitoring QTc prolongation is important with the second generation FLT3 inhibitors, but oftentimes just modifying the supportive care agents that they're on can help to manage the QTc prolongation if it happens, and allow you to continue on at the appropriate dose.
Yeah, I think GI and cardiac are probably the two, and then of course the third is myelosuppression, because we're adding a third drug, and so often we have to, as we have to delay the cycle sometimes, and we cannot be rigid about the 28-day cycle that sometimes people get very rigid about in the community. So often we do see cycles go out to 35, 40 days, and as long as we're monitoring closely, confirming remission, I think this is okay. But both gilteritinib, midostaurin, as well as quizartinib, which we have used quite extensively, are quite well tolerated and safe drugs in general. We do not see too many symptoms or issues with them. And in general, I think we have been able to administer these FLT3 inhibitors to almost close to 100% of our frontline patients who have a FLT3 mutation. I cannot think of a scenario where we would say, I absolutely would not use a FLT3 inhibitor. We may shorten the duration, adjust the doses in certain patients, but I think our goal at MD Anderson has been to give FLT3 inhibitor for all FLT3 mutated frontline patients.